This is a standard delivery. So when a patient becomes fully dilated and she can't stop herself from pushing, there may be a time where you may have to do a delivery on your own. And the delivery is pretty simple. You see the head is beginning to protrude. If you're doing a delivery on the own, the whole key is to allow the baby's head to deliver on its own. Don't pull it out. Once the baby's head is delivered, we have to rotate the baby. If it's OA, we have to rotate the baby in an OT position such that there's an anterior, posterior shoulder. And you'll see the doctor rotate the head and then deliver the anterior shoulder by giving a little downward pressure. Once that anterior shoulder delivers, the posterior shoulder should deliver very easily. The rest of the baby comes out nice and easily. And then in this model, what we would do is clamp the cord here and use the plastic cord here and then cut in between and then put the baby in a blanket. Part 2 of a standard delivery is to deliver the placenta. Sometimes you'd wait 30 seconds or so, begin to crede on the lower uterine segment, and that would begin to contract the uterus, which would cause the placenta to begin to shear off the wall of the placenta, off the uterus, and then at which time you give some downward traction to the cord and the placenta will deliver. Once the placenta is delivered, we would put 20 units of Pitocin in an IV bag and run that at 125 cc's an hour to cause uterine contractions, to cause the uterus to clamp down so that it doesn't bleed any further. And that's a normal vaginal delivery.